If you find yourself confused by hepatitis C, both the labs to order, how to interpret them, and then your role as a PCP, this video is all about that. If you're new here, I'm Liz Rohr from Real World NP, and you're watching NP Practice Made Simple, the weekly videos to help save you time, frustration, and help you learn faster so you can take the best care of your patients. So also included in this video is going to be a cheat sheet, so definitely download it below this video, print it out, keep it at your desk for quick reference, got some great extra resources too if you want to learn more. Also, if you're on a lab interpretation journey, if you'd like to join us for the lab interpretation crash course for new nurse practitioners, it opens next week and I'm so excited. So if you're interested to get on the wait list to get emails about that, it's realworldnp.com/labs, and then I'll give you all the details there. Without further ado though, I'm going to share my screen with you.
So this is the Hep C case study. So this is John. He's a 32-year-old man. He's a new patient to the clinic. It's not his real name or his photo. So he's establishing care with a new PCP. He hasn't seen a doctor in 10 years. I don't know if you see this come up. I see this come up quite a bit. He wants to, quote, get tested for everything. This is chief complaint. And typically when I see this, not to typecast, but I think typically when I see this, there's really more going on to the story than patients are kind of willing to volunteer at the time. So I tend to treat those visits kind of gently and just making sure that I'm being really sensitive to, is there anything underlying that it's kind of like the real story of what's going on. So he's a current smoker. He smokes 1 pack a day. He formerly used nasal cocaine with occasional IV heroin use. He's still kind of using here and there, but trying to get a history. I try to ask these questions, and if you want me to get into this more in terms of obtaining a history, I'm definitely happy to. But I try to be very open and not judgmental. Things like, oh, okay, so like when was the last time you used heroin? Like, are you still using right now? Is it like every day, a couple of times a day? Kind of like, bringing it from offering the scenarios that they probably would be embarrassed to admit, that most patients are embarrassed to admit, and kind of taking it down from there, because most patients will happily volunteer. Oh, no, I just used heroin like 1 time, like last month, that kind of thing. So anyway, let me know if you want me to talk more about that. He has no current sexual partners, but he, quote, dates. And again, he wasn't really forthcoming with this history either. And I had to do a little bit of kind of asking it a couple of different ways to get some information, but it is what it is. And sometimes that's just what happens when, at least for me, when I get patients and they first come in and they don't really want to disclose, they haven't been in healthcare for about 10 years. They don't really want to get into some stuff. They just really want to get the answers that they're looking for. So, no known family history, past surgical history, past medical history. He doesn't take any medications. Blood pressure is normal, 130/70, heart rate of 70, oxygen and respiratory rate are normal, and his BMI is also normal at 22. So I'm going to be talking about Hep C in this particular video, but I'm going to touch on the other components of his holistic care at the end. So one kind of minor note is that I'm trying to, as I progress in my career, I think that in general and in this country, we over-test. And I think a lot of new nurse practitioners really worry about that, ordering too many tests. And I think it's something that you can be mindful of, but don't stress out too much about, especially if you're brand new or if you're still a student, because that's kind of how we all progress and how we all learn. But I'm trying to be more mindful of it and really make solid decisions about when to test labs for people and when not to. And I still feel conflicted about it. I don't feel great, but there's no real guidelines about ordering like a CMP or a CBC for this patient. So really I focused on his risk factors. And so I only tested for him Hep C antibodies, HIV, because he has risk factors of IV drug use, which I'm going to talk about in a second. Hep B surface antigen and antibody. If you haven't watched the Hep B lecture, definitely go back and do that. That was last week. We'll kind of help you feel comfortable with those labs, but just looking for that because I wasn't able to get like a clear history in terms of his sexual history about condom use and how many partners and who his partners are and things like that. Syphilis testing RPR because it's one of those sexually transmitted infections. It's on the rise. There are certain populations where it's in the rise more so than others, but I believe that IV drug use kind of also predisposes you to that. And then gonorrhea and chlamydia, I have a star here because really I actually could do a whole video about sexual health history and testing. And I'd love to go into that, but I'm a little worried about getting censored by YouTube. So I'm not going to get into it super a lot right now. But you really want to make sure you're testing all the sites of exposure, not just a urine sample. And so really getting a good history about that with your patients and kind of who their sexual partners are and things like that, how they find them, et cetera, et cetera. Anyway, I can't help myself. I love that topic. So definitely let me know if you want to hear more about it. So results for him, his Hep C antibody is positive, his HIV is negative, his hepatitis B surface antibody is positive. Hepatitis B surface antigen is negative. His RPR is negative, and gonorrhea and chlamydia, with the star that all his sites tested were negative. So important background before we get into the kind of nitty gritty of this case. So Hep C is a virus similar to Hep B that affects liver cells. 70% of patients are asymptomatic. So about 6 weeks after exposure, they can start to have some symptoms where they can have like this malaise and fatigue, and some patients can have jaundice, elevated AST, a little bit more than ALT or AST really. Conversely to Hep B, though, most patients do not cure it on their own. Only 50% of them, max 50% of them, cure it on their own, and typically about 15 to 50%. So about 50 to 85% of patients go on to develop chronic hepatitis C that doesn't go away without treatment. So of the people who have chronic Hep C, about 5 to 30% develop cirrhosis, and that typically happens over the course of 20 to 30 years. So scenarios that you just kind of some background as well. Scenarios for testing. You could either be screening or you could have somebody who's symptomatic, and basically the testing is the same. So screening, you really want to think about patients who use IV drugs or intranasal cocaine as well at any point, even if it was just one time, you definitely want to test those patients. Patients who are high risk, continually high risk, or have risk factors. Patients who are born in 1945 to 1965 have a higher prevalence, so there's recommendations to just make sure you test them at least once. Patients who have HIV, were incarcerated or currently incarcerated, men who have sex with men have higher risks, and patients who are on dialysis as well, and a certain other ones about organ donation or I believe transplantation. But if they're involved in transplant, I'm sure somebody's going to be screening for them for that anyway. But FYI. And then if you have someone with slightly elevated LFTs, definitely go back and watch that lecture if you haven't watched that already. Or if you have patients who are kind of symptomatic that you are worried about, or actually I didn't include here post-exposure, patients who used IV drugs or had sexual relations with somebody, less commonly sexually transmitted, but another thing to think about. And again, going in just a second, I'm going to go through the labs and I'll talk about kind of like when to test for which labs. But yeah, natural course. Oh, and that should say Hep C, not Hep B. HCV RNA. So when you're exposed to the Hep C virus, the RNA level, similar to the DNA level in hepatitis B, is going to be positive in about 1 to 2 weeks after. So if you're thinking about somebody who has had an exposure to sharing IV drug needles, something like that, you can test the HCV RNA first, but again, it won't become positive for 1 to 2 weeks. The patient can become symptomatic about 6 weeks after they're exposed. If they do, again, 30% of them do, 70% of them don't. And then the patient will clear the infection, if they do, around 6 months after exposure. And that is also the time where you're going to see that hepatitis B antibody positive. And then once you get that hepatitis C antibody, it's going to be positive for life. And that becomes positive about 10 weeks to about 6 months. And then chronic Hep C is when they have persistently positive HCV RNA levels, and that will kind of confirm that they currently have an infection. So again, I probably should have put this one first before that slide, but the two labs you really want to think about are Hep C antibody and Hep C RNA, way, way easier than Hep B. In parentheses here, I also have the genotype and the fibrosis score, but hold that thought for just a second. So treatment for Hep C, it's basically 3 months worth of antivirals. And this used to be with like interferon and like this whole regimen that was really hard to tolerate, really high side effects. Basically what's happened now, it's very expensive, but it's only 3 months of medications and then they're cured basically forever. I mean, there's very low not curing rates for them. And then there's a couple of them, and I have them by trade names, I apologize, because the generics are really hard to pronounce, and these are kind of the main ones that you might see kind of people talking about. Harvoni, Mavyret, Epclusa, Vosevi, and then there's a couple of other ones. And again, the generics are kind of coming out as well. And typically this is treated by GI unless you have a comprehensive program in your clinic with like a nurse case manager and you're collaborating with the GI to ask questions, things like that. And it really depends on the genotype that they have, how fibrotic they are, like if they have cirrhosis or not, and then previous treatment they've had in the past, if they have any impaired renal function, medications they take, and then comorbidities. So how this really relates to you as a PCP is if you kind of walk into a situation where you have somebody who's on their chart that they have hepatitis C, and the last note from the provider was like, oh, continue follow-up with GI. And you're kind of just dropped into that, and that's all the information that you have. This is kind of informing you of like what the deal is, right? So have they had treatment before? How do you know? And they really, like, if it was discovered like 10 years ago, like hopefully they've had treatment. I'll talk about why they wouldn't get treatment in a second, but The test that they need to do first before they do treatment is something called a fibroscan, and it's a type of ultrasound that the GI doctor will do, specialist will do rather, that is a less invasive way than doing a liver biopsy to determine if they're on their way to cirrhosis or if they are cirrhotic. And then the genotype that they have, I believe there's 6 of them. I can't remember now off the top of my head, but BUN and creatinine, you want to make sure that that is in the normal range or within an acceptable range to treat them. So reasons not to treat. So this is why it's kind of important to you as a PCP, because if you have a patient with active Hep C that is not getting treatment, you still need to monitor them, especially if they're not willing to go to GI, which happens. So patients who are at risk for reinfection, so if you have active IV drug use and you are either don't feel ready because you're not confident in your sobriety, or you're not quite ready to, they're just not quite ready with sobriety, because that's a chronic illness, substance abuse disorder, right? So if they have risks for for reinfection, then they may not want to treat it right then. And then patients who have cirrhosis, the reason why is not that we won't treat them, is that patients who have cirrhosis may be heading towards liver transplant, and it's much easier to get a Hep C transplanted liver that has Hep C, and then you treat after transplant than it is to treat before transplant, et cetera, et cetera. So monitoring. So this is why it is kind of important to you as a PCP, even if you're not treating them. So you want to the patients who are not getting treatment, you want to reduce the risk for transmission. So are they using clean needles? Are they sharing needles? If they have IV drug use, risk factors for progression, you want to make sure that they're minimizing those. So obesity, diabetes, things that can cause fatty liver, alcohol use, Tylenol use, some medications. You want to make sure that they avoid those things to make sure that it's not progressing their Hep C, making their cirrhosis worse. You want to make sure that they have their hepatitis B and A vaccination. So that's kind of like, this is part of like your care plan when you run into somebody who has Hep C, making sure that they have those vaccines. And if they don't, then you give it to them, because if they also get concurrent Hep B, that could be a lot messier and a lot more severe of a case, according to my GI specialist. I've never seen it. And then substance abuse treatment, again, because this is a mental illness, it's a chronic illness. We want to make sure that we're supporting them, getting them involved with psych if they need that. And then in terms of the monitoring of LFTs and fibrosis scoring, I really would reach out to your GI specialist if the patient's not willing to go, because they can make their recommendations going forward about, like, is this every 6 months, 3 months, et cetera, et cetera? Is a fibrosis score once a year? Because again, if you have a younger person with IV drug use versus somebody who was born in 1965 who happens to have a positive Hep C, like the person who's had it for a long time is more likely to have fibrosis than somebody who just acquired it, if that makes sense. And I have this in parentheses just as an FYI, because I have run into this case a number of times in a setting that I used to work in. But if you run into this, I definitely would be collaborating with your supervisor. But patients who have chronic Hep C and cirrhosis, you want to make sure that they have all the monitoring parameters in place. They really should be connected with GI to help you with this. But if they're not, you run into it from time to time, like I said, but still manage it with your supervisor. But just FYI, you're going to be monitoring a every 6 month ultrasound for hepatocellular cancer. They're going to need an endoscopy for esophageal varices typically. And then they may monitor them with something called a MELD score, which is a calculation of a couple of labs to kind of give their prognosis of how they're doing with their cirrhosis. So kind of bringing it back to the real, like, basic, simple stuff. So that's just some background information. If you find yourself running into somebody with Hep C and you're just like, well, what do I do with that? And this is what you do with it, is you evaluate if it's active or not. And then you make sure that they have seen GI, they're doing treatment, why they're not doing treatment, et cetera, et cetera. So number one, Hep C antibody test. Awesome, right? If that's positive, then you want to do the next test you want to do is the HCV RNA to verify if it's actually active, right? Because Hep C antibody is going to be positive for life. So if the initial Hep C antibody is negative, you can stop. I do want to make a caveat here, though. Based on that timeline, I should have included it here as well, but based on the timeline of infection, depending on the scenario we're talking about, if you have somebody like in this particular case who recently used a needle from somebody who know that they have Hep C and they want to test today to see if they have Hep C, you can't do the Hep C antibody until it's been about 6 months. So hopefully in your history, you've gathered when their exposure is, so you don't just do a Hep C antibody for them and then it's negative because they haven't developed it yet and they have active Hep C, that kind of thing. So again, you can check that HCV RNA first in 1 to 2 weeks if you're worried about a post-exposure testing. Or if they have risk factors for a recent infection, you could theoretically do that at the same time, which I guess I could have done for this patient, but it is what it is and it's all done. So it's something to think about going forward. So if your HCV RNA is detectable, do they qualify for treatment? Do they want treatment? Do they have risk factors for reinfection? Do they have cirrhosis? And then consider those pre-treatment labs and monitoring versus sending them straight to GI, because that's kind of like your next step. Versus if you did the Hep C antibody and it was positive and the HCV was negative, there was no viral load, it was 0 or less than 20 or however it's reported, you can stop there because it's signs of a previous infection. So yeah, so kind of quick recap with him. So I checked the HCV RNA, and theoretically, I could have checked the HCV. I could have checked that at the initial test, depending on what his exposures were. And his HCV RNA was 800,000. And so what I want to talk with him about is that the natural course is that about half-ish people will cure it on their own within 6 months. And so we don't necessarily know when he was infected with this, right? And so typically insurance wants you to have that documented for about 6 months before they're willing to approve the medications, because again, it's quite expensive. However, don't let that kind of deter you, but just medically manage them and keep that in the back of your mind. Probably he needs to go to GI though, right? Because they're going to help you with the testing and the counseling and all that kind of stuff. Again, FibroSure or FibroScan. FibroSure is like the blood test that you would do if you didn't have access to a FibroScan, but that's ideal. So definitely want to see GI for that. Genotype, and then a BUN and creatinine. And then kind of just quick recap. So John, I'm concerned about a chronic Hep C versus an acute Hep C, and there's really no labs to tell you that, how acute or chronic it is. Sometimes a viral load can give you some information, but for him, I did some pre-treatment labs because he was really freaked out about it and he really wanted to get treatment, and I referred him to GI as well to help with that FibroScan. So I really just did the genotype testing, and that's pretty much it. And then we talked about some sexual health counseling, some risk reduction factors. I offered PrEP for him. And if you're not familiar with PrEP, I'm happy to make a video about that. That's a pre-exposure prophylaxis for HIV for patients who have risk factors for, sexual health risk factors or IV drug use. Declined at the time, but something to think about. So substance abuse counseling, I brought that up as well. And if he's interested in continuing or stopping heroin, and smoking cessation as well. But typically patients are in the middle of a new Hep C diagnosis and active IV drug use. They typically don't want to quit smoking, but you can mention it and just say, I recommend that we don't do that, but we can tackle that whenever you feel ready for that kind of thing. And then for him, I recommended that he came back for a full physical in 1 to 2 months, just to make sure we're talking about all the things we want to talk about going forward.
Did you like this video? If so, hit like and subscribe and share with your NP friends so together we can reach as many new grads as possible to help make their transitions a little bit easier. And if you downloaded the cheat sheet below this video, you're also going to get the ultimate resource guide for the new NP if you haven't gotten it already. You'll get these videos sent straight to your inbox every week with notes from me, patient stories, and bonus content that I just don't share anywhere else. Like I said, if you're interested in joining us for the lab interpretation course, join us at realworldnp.com/labs. It opens up next week, and there's going to be some fast action bonuses for if you join early. And there's also a Facebook group with it. There's live support from me. There's so many things. So definitely hop in there if you're interested. Thank you so much again for watching. Hang in there, and I'll see you soon.